Alright, and welcome to Diabetic Emergencies. So, like a majority of this class, we're doing a lot of review over, and very basic review, over some of the more commonly seen um, medical complaints or complaints that are most commonly seen in the pre-hospital setting. Um, so, so we'll just start off with diabetic. We'll just do this thing on diabetic emergencies. It's not going to be anything groundbreaking, but hopefully it'll give you a review of some of the pathophysiology of diabetic emergencies and maybe bring in a new idea or two into your brain. So that normal metabolism, right? That aerobic metabolism is, you start over here kind of at 11 o'clock where food is ingested. You got adequate insulin. Insulin's going to open that door, right? That facilitated diffusion to glucose, and then glucose is able to enter the cells. And then once the glucose is used by the cells for energy, right? We get ready for that next meal. And then, for some of us, it's just a constant grazing all day long. So we talk about that normal, the normal metabolism. We're all will address that. There's some folks that don't have that normal metabolism or the ability to process glucose as efficiently or at all. So you got diabetes, right, or sugar diabetes, or the sugars, or kind of depends on what part of the country you're in. So diabetes mellitus, it's the inability, right, or decreased production of insulin. So either you can't produce it, or you have a decrease, or your body doesn't recognize your insulin. Either way, the it's not used properly, insulin, by your body. And so with glucose, right, it's important to remember that is the basic form of energy. Kind of depending on where you're at in terms of current diet trends or health and fitness or whatever, you'll see folks that say that a ketotic diet is brain saving, is heart saving, and so on and so forth. And it may be, but eventually, right, even a ketotic diet has to create sugars because that's what the body's using along with those ketone bodies. So that's kind of a comment for maybe for another time. So insulin, remember, is a hormone produced in the pancreas, and basically there's two cells or two types of cells that are going to be produced, right? There's the alpha cell, or the alpha, and the beta, and the alpha is that glucagon, and the B, or that B is the insulin, and that glucagon is what stimulates the breakdown of glycogen. So while the pancreas is important in the production of glucose levels, or that it's not as important as the liver, for instance, in raising glucose levels. So the pancreas really, its primary responsibility is the production of of insulin, and the liver actually does a little bit more in the raising of glucose levels. Without insulin, right, sugar is unable to enter the cells, and gluconeogenesis is going to be that breakdown of fat and protein to form glucose, or that sugar. And then insulin is going to be secreted, right? We eat, we've got that protein, fat, and carbohydrates that comes into the body. The insulin is released, and it's going to lower that blood glucose level by increasing the uptake into the cells. Okay, so it's the key that allows sugar to get into the cells. And then, right, the liver is going to remove that circulating insulin within about 10 to 15 minutes after secretion, right? So after that, uptake or reuptake by the liver occurs at about 10 or 15 minutes. Right within about 90 minutes, blood sugar level um, should be back to normal. Right. So so we need a steady supply of glucose, and insulin's going to increase right that rate that glucose enters the cell, and it can increase up to about maybe 10 times the go back about 10 times the normal rate at which glucose would get into the cell. So there's a couple of requirements for insulin effectiveness. Um, One, there has to be enough insulin circulating in the bloodstream to satisfy what the cells need. So, and then insulin has to be able to bind to the cells in a way that can meet that cellular need or stimulate um, or maintain that adequate level, right? So, for jumping ahead a little bit, the first one is the kind of that type 1 diabetic, right, where they don't even produce any, and so they have to have some supplementation. And then for the type 2 diabetic, actually it can be kind of both, right? It can be sufficient insulin, or the body's not binding to it the way that it should to be most effective. So when blood glucose attacks, right? So when blood glucose is not taken in by the body, by the body cells, the body responds by a couple of ways, right? It switches from glucose for energy to fat, and in making that transition, fat metabolism or metabolism based off of fat fuel source is not as effective, but or efficient, but it can be effective. So when we're breaking down this fat, we're going to break these fats down into free fatty acids, and this concentration of fatty acids is going to rise in the body. So that the acidity of the body, or that acid's going to rise in the body. And so these fatty acids are going to be used by cells for energy. So, fatty, 2x4, couldn't get through the front door. So these fatty acids are going to be used for energy. It's pretty efficient. It's not like the most efficient, particularly in the short term, if your body's not used to this type of metabolism. Like, in the very short term, a couple of a day or 2 days, the liver's going to take in some to produce glucagon. But what'll happen is, it'll be fine to support life to a certain degree. And actually, it's fine to support life. But like if you were going to run a marathon in the first couple of days of this sort of metabolism, you would bonk rather quickly, right? Again, talking about some dietary stuff years ago, the Atkins diet was super important, and folks that undertook that diet at about day 3 or 4 started experiencing what's called the carb flu. So they'd have this big decrease in overall energy levels. They'd feel, like they had the flu. So anyway, so the liver's going to take in some of these fatty acids, and then that breakdown in the liver is going to produce another acid. And then when fatty acids are broken down, when more of those fatty acids are broken down, then they can be utilized. That excess acid, along with acetone and some other acids, hang out and accumulate in the body, right? And that's when it becomes dangerous for folks, right? So these ketone bodies, interestingly enough, there's been some studies that show that the heart kind of preferentially uses ketones as a fuel source. And again, like in and of themselves, this breakdown of fatty acids and the use of ketone bodies isn't dangerous. However, it depends on the individual, right? It depends on the patient. So, interestingly, I'm gonna back up a couple of slides here. Let me see. Yeah, so years ago, one of the first treatments of diabetic patients was to actually, and we're talking in the late 1800s, one of the first methods of dealing with folks that had diabetes was to basically put them on like an Atkins type diet, right? So the reason is that over time their body would move to utilizing um, would move to utilizing fat as a fuel source, hence decreasing the need for insulin. Um, and folks actually did fairly well with that. So normal blood glucose, the average for a fasting individual, for instance, 80 to 90 milligrams per deciliter. And then after a meal, so about an hour or so, hour to 90 minutes, um, blood glucose gets to about 120, 140 milligrams per deciliter. From there, we're going to transition to these folks that tend to be the reason that we get called, right? So these diabetic emergencies. We're all aware there's two types of diabetes. There's type 1 called juvenile onset. Excuse me. These folks are insulin dependent. They don't have the ability to produce insulin, or they produce such a small amount that it doesn't influence the body's ability to get glucose into the cells. And these folks require supplemental insulin at least once a day. And nowadays, these folks use, the insulin pumps, and it's kind of that, pancreas in a pack, and has really, for a lot of folks, increased the quality of life. Then you have type 2, which is the non-insulin dependent diabetic, and I think more and more we're kind of finding that maybe that's not the case, that we're seeing a lot of type 2 diabetics that are insulin dependent because their disease process has progressed, if you can call it progressing. Um, and so these folks don't produce sufficient amounts of insulin, or they produce, another thought is that they produce sufficient amounts of insulin relative to where they were, but for instance, that they've become so obese that the same amount of insulin is being produced, but it's not sufficient to kind of fuel all the new cells that are there. There's also an idea that the body's not able to utilize it appropriately, the insulin, and that there's some blunting going on at the receptor sites that don't allow for insulin to get into the cells. So there's kind of a variety of reasons. There's not one more prevailing idea than the other at this point. Um, so a lot of type 2 diabetes is associated with obesity, and while that used to be the case kind of in 10 or 15 years ago, that's not so much now. We're seeing fairly what phenotypically, or if you were to look at folks, they would look like they are normal, fairly healthy people, but they're actually developing type 2 diabetes, and a lot of that has to do with kind of diet and lifestyle stuff. Most of the time, I said previously that some of these folks are actually progressing to insulin dependence, but most of these folks are controlled with diet and oral medications. Something that's kind of interesting, or something to just kind of think about, is that there's a strain of thought that type 3 diabetes is actually what we refer to as Alzheimer's, or that Alzheimer's is type 3 diabetes, and that there's some sort of blunting effect that's going on in the brain as a person ages, and there's some researchers are looking into whether or not that is genetic or age dependent or diet, or it's a really complex sort of process. So anyway, that's kind of an idea that's floating around, is that Alzheimer's may be type 3. So another type of diabetic emergency that we most commonly see are, right, the type 1, the type 2, and then maybe hypoglycemia, right? So the hypoglycemic patient is what we refer to as insulin shock. They've got too little insulin, so it can be caused because they've got too little insulin. They're not taking in enough sugars by eating. And you may even see hypoglycemia. You see it a lot, or not a lot. People say they have hypoglycemia. And sometimes you'll see it around like the holidays, perhaps, which I know kind of flies in the idea of conventional wisdom, or around summertime when folks are trying to get, beach ready. So, little sugar intake, over-exercise or overexertion, up to and including even a like an infection or some sickness, and then vomiting that empties the stomach of sugar, right? So even someone, for instance, someone that may have an eating disorder may be susceptible to hypoglycemia. So that may be something that you need to look at. So that bulimic that's kind of vomiting up stuff while they, people report that they have a normal diet, they may actually become hypoglycemic because of as a side effect of their disease. Um, so hypoglycemia can occur, can create permanent brain damage if sugar is not replenished. A lot of times the onset's going to be very rapid, cold, pale, clammy skin, and no odor to breath. And this, I think, is one of those areas where we've done maybe a poor job of informing law enforcement, for instance. You get that call out, or you're at a wreck scene, and the law enforcement says, hey, this guy may be diabetic. They've got that fruity smell to their breath. Well, what they're referring to is hypoglycemia, but as we know, that's not a hypoglycemic symptom, right? That's a DKA symptom. That's an overabundance of sugar, not an underabundance. So anyway, sometimes that's just kind of our poor education. Either way, it doesn't hurt to do a finger stick and just rule out something. But most of the time, it's just going to be that they've just had too much to drink. Um, so in hyperglycemia, it's going to be that there's too much sugar in the bloodstream and not enough insulin to get that sugar out of the bloodstream. Infection and stress, or an increase in food intake. Imagine that. If you eat more, you get more sugar in your body. Um, it has a slower onset. You have that warm, dry skin. You may have a fruity or acetone breath, but that's only true in kind of one case. And there are two types of severe hyperglycemia. There's diabetic ketoacidosis, which we're all very aware of, and then there's the HHNK, right? The hyperglycemic hyperosmolar non-ketotic acidosis, right? And so we'll find out kind of what group that goes into here in just a second. So diabetic ketoacidosis, it's a life-threatening condition, type 1, for the type 1 diabetic. Insulin deficiency, increased glucagon activity, so the liver's doing a little bit more work. Low blood glucose in the cells causes more production of glucagon, which puts more glucose in the blood, and then the body tries to switch this fat metabolism. The problem is, as compared to an individual that is already, or that is switching to a ketotic diet, is that you still have this abundance of sugars floating around in the system, so it's not really regulated by dietary intake. So the body's going to try to switch to that normal, or try to switch to that fat metabolism. So what happens is those ketone bodies start to raise or increase. The body becomes more acidotic, right? So it can decrease actually in the pH to 6.9. So remember, we're trying to stay in that 7.35 to 7.45 range. So we're a little bit alkalytic. And the onset on this, on DKA, is 12 to 24 hours. So it's kind of a slow onset, but if you think about it, right? So these folks, they eat, they don't have enough sugar, whatever happens. They eat more, they don't have enough insulin to get that sugar in, so you get more sugar in their body. And so they're just kind of, their body's saying, hey, feed me, Seymour. But they don't have any way of getting that food that they're processing, that sugar that they're processing, into the cell, so it's just floating in the bloodstream, right? And so the body's response to that is, hey, we should produce these ketone bodies, okay? So that's got that slow onset, where in the hyperglycemic hyperosmolar non-ketotic acidosis, or the HHNK, is seen more in that in the type 2 diabetic, right, the levels of the blood glucose levels were actually going to be much higher than in DKA. Now, with that being said, it's not life in a vacuum. So, for a lot of folks, especially the type 1 diabetic, you may see levels as high as 400 or 500, um, and then be symptomatic. But then they may not be symptomatic, but it would be doubtful, right? Anything over about 200, they're usually going to be very symptomatic. Um, Same with these folks. It's a little bit it's a little bit more insidious, right? So it occurs over a couple of days. There is no ketone production, so there's no fruity smell, um, and no Kussmaul's respiration. And this is going to occur over several days, right? So, and then the same triggers can cause it, right? So infection, so on and so forth. Overeating, you might even kind of lean towards this in the holiday time. So, a couple of signs and symptoms of diabetic emergencies. So, for hypoglycemia, and then relatively speaking, DKA, it has a rapid onset. They may have an intoxicated appearance, right, in either sort of setting, and that's just due to the lack of sugar making it to the brain. Okay. Cold and clammy skin is one, but in just a few slides, we'll kind of differentiate between the type 1, the type 2, and the type 3, or the DKA, HHNK, and then the hypoglycemic signs and symptoms. Elevated heart rate, hunger. The hunger is going to be more prevalent in one than in the other. Anxiety or uncharacteristic behavior and anxiety, and the reason for that is, yeah, you're exactly right, is going to be that decrease in the availability of sugar to the brain. You may see combativeness, and that combativeness may be due to, again, that altered mental status, that uncharacteristic behavior, that lack of sugar to the brain, and they're really kicking in that sympathetic nervous system. And they may have seizures, right, because they're not getting the brain the fuel that it needs, and so they're starting to have these disturbances. Plus, with some of these guys, especially the HHNK and the DKA, you'll see a fluid shift perhaps over a period of time, and that can also influence the electrolytes that also affect neuron connectivity. So now let's just take a look at a breakdown of the causes, signs, and symptoms of DKA, H and K, and hyperglycemia. So, starting on the left, right, we've got the causes, and so in that DKA, cessation of insulin injection, so they stop taking their insulin. That physiological stress, an infection or surgery, or just increased glucagon effects and increased glucagon effects and blocks insulin effects. So, got this blood sugar problem. We don't have enough insulin. The liver starts kicking in and pumping out a lot of glucagon. That glucagon blunts insulin's ability to get fuel into the cells. And remember that alpha cell off that pancreas too is kind of producing some glucagon. So those two in conjunction, the liver and the pancreas, have a pretty good influence and can kind of be almost opposed to what the body's trying to do, even though ultimately they're trying to just keep you alive. So with the HHNK, physiological stress, right, infection, stroke, overeating, and so on, and then hypoglycemia, the causes can be that excessive insulin administration, excess insulin for dietary intake, honestly not eating, right, overexertion, infection. The causes on this table are not exclusive. So the signs and symptoms, and this is where it gets a little bit different. Okay, so for the DKA and the HHNK, you're going to have, it's going to be very similar in the excessive urine output, increased thirst, and increased hunger, right? So the urine and the thirst has to do with trying to get rid of all these sugars and then trying to replenish fluids. And then that increased hunger is the body saying, the body knows that there's this sugar kind of laying around, but it also knows that none of that sugar is getting into the cells. And so it just, the body's like, hey, I need to eat more. I want to eat more. I need more. But in that hypoglycemic patient, you're not going to see that. You'll see warm, dry skin, mucous membranes in the DKA and the HHNK, so they're very similar, right? But in the hypoglycemic patient, you'll see cold, clammy skin. Okay, nausea and vomiting. In the DKA patient, you'll be tachycardic in both the DKA and the HHNK, but the pulses may be normal in terms of strength, right? And then with the hypoglycemic patient, you may have that weak rapid pulse. From the breathing standpoint, right, that Kussmaul's respiration is going to kick in for the DKA patient, trying to blow off the excess acids, right? So metabolically, you're acidotic. Body's trying to blow off using one of the first piece of the buffer system, which is the respiratory system, and then but while in the HHNK, you're not going to see the Kussmaul's, and it's because there's not any ketone bodies being produced. And then in the hypoglycemic patient, right, they may start off kind of breathing a little bit more quickly, right, more of a rapid breathing, but then slowly become a little bit slower in their breathing pattern. All three are going to have decreased mental function, and then all three can lead to a coma and death. Okay, so kind of the big one, right? And you're like, well, hey, why'd you even bring up HHNK since it's so similar to DKA? Well, there's a couple of reasons. One primarily is if depends on your glucometer. For a lot of pre-hospital, right, at a certain level, depending on where it is that whatever monitor your service is using, it's going to say high or something, alluding to that there's a high level. But for some, you may see 400 for somebody that's just not feeling well, and you're like, I don't know how this person's even functioning. Well, if they're that type 2 diabetic, they may be functioning, right? Because they are getting a little bit of sugar in the body. And sometimes they aren't even symptomatic until well above 400 or 500. So that's kind of the primary reason. Now, I just want to shift gears a little bit and talk a little bit about glucose meters. They're measured in milligrams per deciliter. Measures the amount of glucose per milligram per deciliter, but also may be represented as a percentage. And so, one of the things that you need to make sure, and I would assume that your services that are making these purchases of these glucometers, that they're calibrated for multi-use on patients, right? So some glucometers are used just for an individual, they're not designed to be used by multiple different patients. So that's one thing you need to make sure that the glucometers your service is using actually are for multi-patient use. Kind of some common sense pieces here. So always use your glucometer, not the patient's glucometer, with the idea that yours is calibrated or is kept up to manufacturer's recommendations, and that it's user ready for every patient every time. Readings 60 to 80 milligrams in a symptomatic diabetic may actually be normal for them. You may see folks or they may be symptomatic even at 60 to 80, even though they for a normal individual that would not be anything to be alarmed at. Conversely, you may see folks that are functioning and still speaking, but just not feeling well at 20 or 30 milligrams per deciliter, right? Below 60, 50 milligrams or lower for sure, you may start seeing some altered LOC or unresponsiveness. Now, there's a couple of things that can give you the inaccurate results, and some of this is kind of common sense, right? You don't get enough blood, the monitor's going to tell you that. The strips are out of date. Sometimes that makes a difference, sometimes it doesn't, but because we're professionals, we're always going to use in-date materials. The strips aren't stored correctly. We're not calibrating them on a regular basis. And one of the most common mistakes we see in the field is folks using the flash chamber from an IV setup or an IV Cathlon to put blood onto the glucometer strip. Depending on what your strip is, right? It may not be calibrated for that capillary or for that venous blood, but for capillary. And depending on the monitor, again, you may see a 40 to 60 milligram per deciliter difference either way, right? So maybe 40 to 60 above what the actual is, 40 to 60 below what the actual is, or it may be right on time, right? There may be no difference. But the question you should ask yourself is, am I willing to take that chance? For that, so as an example, you've got that patient with altered mental status. They're elderly. They've got a history of diabetes. They have high blood pressure. They haven't been seen. The family goes and checks on them in the morning, and they're not responding right. So the question is, are they having a stroke, or are they having a diabetic emergency? So do you really want to take a chance of pushing for the paramedics out there, pushing D50 into a person that potentially could be having a hemorrhagic stroke, when really what you're getting is just an erroneous reading due to your methodology in getting blood? Now, I've also heard folks say, well, if it's an altered mental status patient, I do it the right way. If it's another type of patient, we do it the flash chamber way. Doesn't really hold up, right? Good practices are good practices, and we have good practices for a reason, because it keeps us consistent and allows us to use kind of the same methodology. And truly, I would be remiss if I didn't say that at one point in my career I actually did that, but that where I've used a flash chamber, but that's been many years ago. And so here's the deal, just a quick primer and reminder on how to do the blood glucose, right? So you're going to use your alcohol prep, you're going to prep the site, you're going to use the lancet to draw some blood, you're going to use a 4x4 and wipe away that first drop, and then you're going to apply the blood onto the glucometer strip, okay? And hopefully through that capillary action, it's going to allow that blood to kind of move up into the strip and allow for the magic to happen inside the little box. All right, so this concludes the lecture on diabetic emergencies. Questions or comments, please post on your discussion boards in class.